All right, let's dive into a really fascinating and kind of strange medical problem. We're going to talk about what happens when the body's internal plumbing gets its signals crossed, creating these bizarre connections that just should not exist.
So I want you to imagine your body is like a house. It's got this really complex plumbing system, right? You've got one set of pipes for solid waste and a totally separate one for liquid. But what if a leak sprung, a really bad one, and it created a rogue pipe between those two systems? That's the core idea of what we're exploring today.
In the medical world, this kind of faulty connection has a name. It's called a fistula. It's basically an abnormal tunnel that the body creates between two organs that are absolutely not supposed to be connected. And we're going to zero in on a specific type, one that links the intestines with the urinary tract.
Okay, now this definition might look a little intimidating, but it actually tells the whole story, and it's pretty cool. Pathologic just means it's caused by some kind of disease. It's not something you were born with. Extra anatomic means it's a structure that flat out shouldn't be there. And epithelialized, this is the key part, means it's lined with cells, creating this durable open channel. It's literally a rogue pipe built by the body against itself.
So let's jump into our first case study. This one is the most common version you'll see, the intestinal fistula. And that's just a fancy way of saying there's a direct, unwanted tunnel between the intestine and the bladder.
So what's causing this? We'll take a look at the chart. The overwhelming cause, we're talking about 2/3 of cases, is something called diverticular disease. This is an inflammatory condition in the colon that can basically just erode its way right into the bladder next door. You can see cancer and Crohn's disease are also pretty significant culprits. So how in the world would you know you have this? Well, the number one symptom is unforgettable. It's called pneumaturia, which is the passage of air in your urine. Yep, you heard that right. Because your intestine has gas in it, that gas can travel through this new tunnel into the bladder and then come out when you urinate. This sign is so specific that for up to 91% of people, the diagnosis is pretty much a slam dunk. Okay, so that first case was all about air moving from the intestine to the bladder. Now let's look at a totally different kind of crossed wire, where the main problem is liquid going the other way. And this difference right here, air in the urine versus urine leaving the rectum, that's the key to telling these two conditions apart. And that brings us to our second case, the rectourethral fistula, or RUF for short. Now, this is a connection between the rectum and the urethra, and its story is, well, it's often tied to the treatment of another major medical issue, prostate cancer. Now, here's the surprising thing. This type of fistula is actually becoming more common. So why would that be? Well, it's because it's often what we call an iatrogenic problem, which means it's an unintended consequence of medical treatment. Life-saving therapies for prostate cancer, like surgery and radiation, are amazing, but they can sometimes damage the surrounding tissues, which can lead to these abnormal connections forming later on. Now, for the really fascinating part, how do surgeons actually fix these faulty pipes? The approaches for our two cases are just remarkably different. It really is a tale of two completely distinct surgical philosophies. For our first case, the one usually caused by diverticulitis, the fix is pretty standard. It's a one-stage procedure, and the interesting thing is the focus isn't really on the bladder. It's on the root of the whole problem, that diseased section of the bowel. So step one for the surgeon is to get in there and pinpoint exactly where that inflamed intestine has latched onto the bladder and formed that rogue connection. Next, they resect or remove the fistula tract itself. This usually means taking out that whole diseased segment of the bowel, and sometimes a tiny piece of the bladder wall where it was stuck, just to make sure the entire faulty connection is gone for good. And finally, the two systems are put back in order. The healthy ends of the bowel are reconnected, that little hole in the bladder gets closed up, and just like that, the plumbing is separate and correct again, usually all in one operation. But for our second case, that rectourethral fistula, especially if it was caused by radiation, oh, it is a whole different ballgame. The tissue in that area is often damaged and doesn't heal well, so you can't just patch the holes. Surgeons have to perform a much more intricate, complex reconstruction. And this is where surgical innovation is just incredible. To stop the fistula from just coming right back, surgeons need to place a barrier of healthy tissue between the two repairs. And where do they get it? They actually borrow a muscle, in this case the gracilis muscle, from the patient's own inner thigh. That harvested muscle, which has its own robust blood supply, is then carefully moved and placed like a living, healthy barrier between the repaired rectum and the repaired urethra. It's just an amazing example of using the body's own parts to rebuild itself. So the faulty plumbing is finally fixed. But what does the road to recovery actually look like after these really complex surgeries? And what can patients expect going forward? Well, the news for our first case is excellent. For those fistulas caused by diverticular disease, that one-stage surgery is incredibly effective. The chance of it coming back is almost zero. You fix it, and it stays fixed. But recovery isn't always a walk in the park. One of the most common hurdles is wound infection, which can happen in up to 1 in 5 cases. It's just a good reminder that even a highly successful surgery still comes with risks. Now for those more complex rectal urethral repairs, the outcomes are a little more nuanced. On one hand, surgeons are very, very good at closing the fistula itself, but because the whole area has been through so much trauma, some patients might face long-term challenges, like incontinence or even needing a permanent colostomy. It really shows that while you can fix the structure, restoring perfect function is still a major challenge. And, this leaves us with a really big, important question to think about. The rise in these complex fistulas is a direct result of us getting better and better at treating diseases like prostate cancer. So as medicine keeps advancing and curing one problem, how do we also master the incredibly delicate art of healing without causing new problems? That's the central challenge, really, at the frontier of modern medicine. Thanks for joining this explainer.